This is Nephrology Nursing Perspectives, the official podcast of the American Nephrology Nurses Association.
Welcome to Nephrology Nursing Perspectives. I'm your host, Lillian Pryor, and my guest today is going to blow your mind. As a healthcare futurist at Deloitte in Canada, an adjunct faculty member at the Rotman School of Management at the University of Toronto, a growth advisor at Teladoc Health in Canada, and an advisor for multiple emerging health startups. Our guest today is an expert in what's next in healthcare. She's here to talk about why the future of healthcare is now, the impact AI will have and is already having on healthcare, and why that's a good thing for nephrology nurses. And so please welcome Dr. Zayna Khayat.
Wow, that was a mouthful. Thanks for having me. I remember meeting you at the symposium, and I thought I like this woman. So then I found out you had a podcast.
Oh, yes. So we are here today, and we're going to begin talking and I guess further discussing healthcare. And I was just in preparation for this, just going through some articles and things. And it said, Imagine Healthcare 2030. And so I guess maybe when we first started talking about futuristic healthcare, right, it seemed like 2030 was so far away. But now, what is that? 5.5 years maybe from now?
Yeah.
So healthcare in the future is actually now. Right?
Absolutely. I mean, when I talk about the future of health, which I did at the symposium, I mean, I'm not being futuristic. I'm not even playing out some of the science we're seeing today. If it comes to light, I mean, you might not even have to have this podcast because we might just cure kidney failure. I'm just talking about, it will be unrecognizable from what we have tolerated, I'm going to say, for the last 50 years. From just some basic blocking and tackling. And exactly as you said, a lot of this is already in practice, standard of care today. It's just not the dominant paradigm. And that's what the future will be in 2030.
Absolutely. And what you brought out actually in your presentation was just, we need to challenge the way that we think about healthcare transformation. And that actually was accelerated, right, by COVID-19. I guess for years before COVID-19, we kept thinking, oh, okay, why can't we do this, via Zoom or via, virtual? And no one really wanted to step out and do that. But COVID kind of forced us to make these things happen. And so we're seeing these shifts, like you said, in how healthcare is provided and the number of factors that kind of, I guess they're driving that shift. You want to talk a little bit about
and maybe I think there's some similarities of the forces that accelerated movement, during COVID compared to what are just the general forces pushing us to the future. So at the end of the day, we're all in the mission of health. And when the ability to deliver care to help restore health, maintain health, create health was stripped away because we had such a place-based paradigm, right? Then we all scrambled because we're like, no, we're in the business of health. And now we're going to find a way to get that health to the people. But I will add, there was a second driver during COVID that added another accelerant that, I think was an artifact of the time, which was, healthcare is also a business, and it's a very big business, particularly in the United States. And so if you could not generate your revenues anymore, you were going to find another way, which is why restaurants went online, so just keep that in mind. We don't really have that driver because, of course, as you know, the demand for health services is fairly inelastic to what's going on in the market. Right. It doesn't go up or down if it's a good economy or a bad economy. Like there will always be demand. And so just keep that in mind. So that said, I think the forces, though, are similar now. And I just kind of organize them into kind of four big forces. So one is, macro in society, like healthcare is in a container in this thing called the world. And the world is changing, so there are, big societal changes around equity denied populations. The spotlight's just been shone. We can't unsee it. So that's actually changing how we design and deliver healthcare services because of our obligations. Climate. Healthcare is the fourth largest contributor of carbon. And the implications of the heating of our planet will disproportionately affect our sector. It will affect your ability to get dialysis to your patients when there's flooding, in the streets or,
Exactly.
smoke. So climate. The third big macro force is I call perpetual shocks and dislocations. So like the pandemic, like climate disruption, like the big cyber breach that just happened in the United States, that basically doctors could not get paid. It ground everything to a halt. I would say Chat GPT is a shock. It just came. It was, in my view, a good shock, not a negative shock. But so you and your colleagues working in a context where you don't know what the next shock will be. Will some big war come out in the Middle East that will now impact your country? So planning in that context is a different way to plan when at any second the whole thing could be ripped out from under you. We've never designed our services and our infrastructure. And then the last is our economic productivity. So our ability to finance any social good, any public good with the way our economy is structured is just under massive pressure. So there's just kind of no more new money coming. And then you add on top of it what's going on within healthcare. Like I just told you, society, those society changes is enough, within healthcare. Patients have woken up. They're demanding more. They have all the data.
Absolutely.
Consumerism. They're just coming to expect a level of service and the transparency, whether our healthcare organizations choose to be transparent, they're going to find out what they got to find out. They're going to find it from everybody. That's a very different monkey wrench in the operations of healthcare, which was kind of designed despite these people called patients. The second is all of our healthcare organizations, systems, they're all have to rebase their business model because it just doesn't work. So, wherever you work, you're going through your own changes of your care model, your operating model, your policies, who does what work, virtual care. I mean, they're all rebasing digital. And then finally, there's technologies here to help us do these changes in a much cheaper, frictionless, more intuitive way, in a way we've never had these technologies available before. So that's the context of all the forces. Think of a pressure cooker. Whether you want to or not, the pressure's on and healthcare will change forever.
Yes. And just the explosion of everything that you said. And I just want to go back to something. We'll touch on it probably a little bit later, but the Chat GPT and the AI in terms of nursing, and particularly nephrology nursing, we have to kind of embrace that, right? It's going to be a help to us. But on the other side of that, Dr. Khayat, I think you mentioned we won't need as many nurses kind of at the bedside. What are your thoughts about that?
So I think these are fair questions people are asking. There's always this fear when you see something, especially when the headlines say, AI will replace some percent of nurses or something. So let's just be really, really clear. No one who's a trained health professional ever loses their job in the future of health. The demand is growing so much, and it's fundamentally a human caring activity. However, everyone's job, or at least it's been quantified, 93% of all the work, and nurses make up half of the work of healthcare. You're half of the workforce.
Absolutely.
Everyone's job changes. And that's where we have a friction point. So will we need as many nurses at the bedside? I don't know. But if you unpack, let's say on an average day at the bedside, a nurse does 60 different tasks. Pick a number. It doesn't matter. I'm just being hypothetical. I'm going to suggest 40 of those 60 do not need to be done by that nurse. Some could be done better, smarter, faster, cheaper by a machine. Some could be done by another trained professional. Some could be done by a civilian who's upskilled at the point of care for some of the tasks. And so that incredibly trained nephrology nurse, if it's at a kidney clinic, now is freed up to really push the scope of his or her practice and deliver the kind of care they got into the profession for. And what we're seeing is upskilling up that nurse might start to do some of the tasks that also just got deconstructed from the nephrologist, the radiologist, the physiotherapist. So everyone's tasks get broken into subparts and reallocated in this much more flexible model. So we use our incredible humans to the best of their ability. And
Right.
maybe it means if the machine can do 40% of your tasks, you now can spend 40% more time understanding your patients. I don't think it's job loss. It's augmentation. I really see it as augmentation.
We often hear that nurses being allowed to practice at the top of their license. And
Yes.
so we have to move away from being task oriented, if you will. Those tasks that take up so much of our time, vital signs and, the charting of it all, 450 places, the same thing we have to keep charting. A lot of that will be removed. And that's
Yeah.
a good thing.
That's a good thing. I remember hearing a nurse say, I didn't go to nursing school to do paperwork all day.
Right.
That is
Right.
sinful to me.
Right.
An analogy I give people, like, I don't know if it's tax time in the United States. It is here in
Yes.
Canada. So imagine if you
finished.
went, and found some person to do your taxes and they whipped out their book and their ledger, their pen, their ruler, and, they started writing your numbers and manually adding them up. Will you be gone out the door before they looked up?
Exactly.
Like, to me, that's the equivalent of all this paperwork and admin and charting that we're asking these highly trained professionals, just like your accountant,
To do.
not
Right.
easy to pass the CFA exam to do. So that's how you have to think about it.
Yes. Yes. That is super helpful and just super important that we need to, again, change our mindset about how we view technology in the future and make sure that we are innovative enough to include it in our processes and make it part of our processes, which we are starting to do.
Yeah. And just, I call them your co-workers, or they're now called your co-bots. Everybody will have a co-bot. You have a coworker.
Mm-hmm.
That's a little machine that maybe have a little botsinality. It might have some botsinality. You can give it, persona, but it's just a machine.
I love that. I love that. We're going to switch gears just a little bit. We're talking about kind of where healthcare is now, right? So we're moving from that hospital-based, like brick and mortar kind of thing to really going to where the patients are. And you said also something about getting to know your patients, and you mentioned a little bit about the social determinants of health, which is where most of the health, right, is, right?
Yeah.
20% of it comes from that hospital or your actual medical care. The rest of it is where you live, where you work, where you're growing
your poverty,
up.
your literacy.
Everything.
And I would say probably, the global average, depending on the study, is exactly what you said. Only around 10 or 15% of the health status is the result of medical care one receives.
Mm-hmm.
So let's say, you got your appendix out when you were 9 years old. Well, yeah, that saved your life. That's amazing. That's medical. Thank you very much.
Right.
I would suggest, though, that for kidney patients,
Mm-hmm.
it's probably like a few percent. I mean, of course, once they're on dialysis or they've had a kidney transplant, that's a different story. But what caused their burden of illness is mostly what I call life sucks disease. All the things that led, us to do things that really to protect our bodies, right? It's a trauma response that preserves resources, and we get obese, and then that causes diabetes, and then off we go, So not dealing with that, we're kidding ourselves if we think we're going to mop up all the dis-ease with sick care resources, right? And so what I'm loving to see, particularly I'd say pockets of the United States are leading in the way here, is sick care organizations, hospitals, urgent care, reallocating their resources, taking them apart and investing, where health is created and destroyed much earlier. And sometimes that's food security programs, housing security, employment security, social isolation, and addressing that because, we can predict what, so that's been really exciting. And I think in kidney care in particular, there's a lot more of those drivers. So you have so many more ways to help your patients well beyond delivering incredible, excellent, high quality nursing care.
Yes. And although I'll speak for myself, although I am grateful that I'm able to serve at the end of the spectrum, I would much rather be upstream and preventing many of these patients from actually needing my services as they are. And
Yes.
so you talked about just some of the, I want to say, talking about upstream and being predictive and
Predictive.
how we're
Yeah.
able to detect, okay, this person, we have these predictive models that are coming out, and this person, going the way that they're going, we predict that they'll be at end stage renal disease or kidney disease in 5 years. So
Yes.
what about that?
Yeah, so this is probably a new phenomenon in the future of health. Like, and all your listeners have been around the block. We've been talking about the word prevention forever. And we're like, oh, that's the job of public health. We're in sick care, Then we've been talking about proactive health. Okay, but the third P now, as you said, is a completely new practice of medicine, truly
Yes.
predictive medicine, predictalytics. It's a whole new branch because we never had the data and the sophistication. And again, particularly for kidney failure or chronic kidney disease, it's no different, in my opinion, from, say, cancer, where we've built entire infrastructure to stratify risk and then screen based on risk strata, right? If we can screen for who's at risk for colorectal cancer or breast cancer or cervical cancer, prostate, we know there's a way better chance, we are going to, it's not cure cancer, we're going to intercept it. We're going to intercept before, and that's exactly what is 100% possible in chronic kidney failure and all kidney diseases. You've got a screener, of course, I think it's the GFR, but there are so many other data points now that can be triangulated because we have so many kidney patients. You can back analyze and get an AI to say, here's the pattern that will predict who's going to get on the path, even if you don't even have the GFR screener. And then again, leading health systems are reallocating their kidney care resources. They know who's going to get failure in 5 years, and they're intervening right there. I'm just going to add one more thing that has yet to happen in your domain, but it's happening in others. There's another layer. So you as a professional, you see the end of the spectrum. You see what happens, and you wish and you dream and you pray and you hope that you can help another patient not get there, right? It is just the devastating consequences are so awful for everybody. Well, now you can start to use virtual reality, which literally immerses your brain in what your brain cannot distinguish is real or not. That's why it's called virtual reality. It's a biological phenomenon. So you put on the goggles and you can let your patient and their family see how their body will be if they keep going. The biological impact of seeing you, that not a picture that they do, these hacks on Instagram, like you feel it. You can see what your life will be if this continues. That's another tool in the arsenal that is very different from you in a white coat telling them, which feels shameful and a bit paternalistic. So we've got a lot of new tools to catch it earlier, predict it, but also intervene in a much more impact producing way.
Yes, that's an excellent point that you want to make, because we've been telling people, warning people for years, this is what's going to happen, even to the point where they've seen maybe their relatives go through this. And that, I think, was my question. What we need to impact is actually how the patients are able to receive it. In a way that they want to change their behavior.
Exactly.
That kind of gets to it and says, oh, okay, I really need to do this because this is going to feel really crappy.
Yeah. And this is just, by the way, like, we're not inventing that. This is called behavioral psychology. The McDonald's and all the other industries have cracked this science a very long time ago. And so, but we want to use it for kind of positive gain. But this is where now other industries bringing their capabilities to our sector is going to make a big difference because they know how to do this stuff. And that's where some of the successes we're starting to see.
Absolutely. Absolutely. This is so fascinating to me. And I'm so excited that we're here. And I'm so excited that you took some time just to kind of to talk with me about it. And I just wanted to, I guess, point out one more thing. So now there's a whole lot of talk and a whole lot of buzz in the transplant sector industry. And so what was that, last month, maybe in March, we saw our first pig kidney transplanted. What do you say about that in terms of the future? And we've been
Yeah.
trying, I guess, but.
Yeah, I think the science is getting better, faster, smarter, and cheaper. I look at what I did. I took 5 years to do my PhD. Like, we were working with mice and, it would take a year just to get one data point to allow me to then go do the next year of research and the next year. Just the science, the efficiencies, the digitization, if you will, of just the methodologies of science is bringing massive efficiency. So I'm talking like 100 to 1000x. So just there's a speed of the science. It's got to go at its pace, but what we stripped out a lot of waste. So that's one. Two is, whether it's a transplant of, traditional, an organ from a dead human, where the science is preserving those organs a lot better now, so that what you would have disposed of before, we can now actually find a way to make it more useful, which just increases the supply. I think the communication infrastructure on transplant is getting more sophisticated, but of course, now there's 3D printing, advanced biologicals, material science that might allow us to synthetically produce some of these things, or to trick our stem cells, which at the end of the day, you and I, when, we were two eggs, an egg and a sperm, there was something in us that knew to grow a kidney.
Right.
So we're, there's a whole stream of science that's tapping that kind of stem cell regenerative medicine side. So, we're kind of coming at it at all these angles. And then I think, of course, for those who can't get a transplant for whatever reason, I think the science and the innovation around dialysis and just taking a lot of the waste, the time, the bad experience out of that is getting better. And of course, now what we talked about, hopefully we will nip it in the bud. This will be like what we're about to do. Puerto Rico is about to eradicate cervical cancer purely.
Wow.
From vaccinating as much of the population as possible. So kind of when you hit a 90% vaccination rate, you can do the math. It'll eradicate. And then very, very sophisticated screening, because the Latina population is disproportionately impacted by that type of cancer. So I could see a day where we're going to look back at this podcast, Lily, and be like, wow, they were talking about prevention.
Remember that?
So I hope we'll stop new cases if people progress, because some people also get congenital, as you know, kidney failure. It's not always because of their socioeconomic context. And I think science will come. I just think that one is going to take a little bit longer, what you just talked about on some of the transplant science and the stem cell science.
Yes, but certainly a lot to look forward to. And it's an exciting time for us, because nephrology, I guess, as a whole, has been the same for since the beginning, since the 70s, right? And so it's really exciting to see that there is so much newness
coming.
Freshness, right? And we're just trying to move it forward, because it's just been the same so much.
Yeah, and I think what is, to me, we talked about scope of practice of nursing, like kidney health and kidney care. It's not one little organ that has a very discrete, tight management. It is so systemic, the causes and the implications. So you really do need to, first of all, understand the biology, the science, the clinical aspects of the whole body.
Right.
In a way, you don't need to just know the organ, right? And then secondly, talk about holistic. You have another layer of holistic, is all that social context of the person. And I kind of even stopped using the word patient lately. I talk about the people affected by kidney cancer.
Yes.
Because that could be your spouse, your child, your mother, for some communities, the whole community is affected when maybe the matriarch got kidney cancer or kidney failure. So as a nurse, that's your training. You do see the whole person. You don't close your eyes to their social context. So it's kind of a double superpower, in my view, the nephrology nurse, which is why I got in an airplane and I hung out with you in Orlando. I mean, I don't normally do these things, but that's why I really agree. I think this is going to be a very, very important milestone in terms of the trajectory for kidney care and kidney health.
Yes, I agree. All right. So I'm going to kind of wrap up right now. And I just wanted to get your thoughts on, you talked about the economic part of this, right? And so we have all of this technology and all this newness. Is it something that's going to be sustainable, right? How are we going to be able to sustain this? And then what do they call it on Shark Tank? Oh gosh, the word is escaping me.
Scale.
Scaling.
Yeah, of course. There's three words:
Right.
spread, scale, sustainability.
Sustainability.
We
Right.
use them interchangeably. So look, let's go back. Remember our accountant example? Okay.
Mhm.
Technology frees up / replaces labor or
Mhm.
other capital intensive things. Okay. That's what technology does. So right now, you and I are having this conversation. I can see you, you can see me, the listeners can't, but we didn't need to create a room that we go meet in person, which is a
Mhm.
capital intensive thing. So that's what technology does. It replaces labor wages and it replaces kind of capital infrastructure, or it hyper miniaturizes it. Like for example, I think I showed at the talk, like the ECG, the original one was a 6-ton massive. It took up an entire room and there
Yeah.
were only like 5 of them in the world. Now, you could buy it on Best Buy and it fits in your wallet. So
Right.
that's what technology does. When you replace things that have a lot of cost, labor,
Mhm.
capital intensive things,
Mhm.
your economics get lighter. You demonetize. It's cheaper. In some cases, it's almost free because it's software. So the economics with technology, in theory, actually get incredibly better. However, our problem, why everyone says all technology has done is add cost, right?
Yeah.
It is inherently not more expensive. Okay, maybe big scientific things that are brand new, that's a very different type of technology. I just
Yeah.
mean basic blocking and tackling, smarter screening, smarter note taking, helping your nurse not chart for, 40% of her
Forever.
day. This is what I'm talking about. Okay. That's, you can see
Yes.
why it hasn't delivered the productivity gains in healthcare the way it has in pretty much every other global core sector is because our producer interests, the business models of our whatever hospital,
Mhm.
don't want, in innovation by default, someone wins, usually the patient, but you're taking apart an old thing and putting it back together in a new way, which means something goes away.
Something goes away.
Something goes away. And translation, technically, someone loses. And so that's what hasn't happened. One of my former bosses used to say, if you're going to add a new methodology, a better way to screen, a better way to do dialysis at home, you need a demolition team at the same time to take out the old. If all
Exactly.
you do is allow every practice we've ever had, like you said, for 75 years to be there and keep adding new, that's exactly a recipe for completely poor economics that will never, ever, one, be sustainable and will never scale. That's the unfinished business. And that takes courage because just like you said, people perceive taking out the old as loss of wages, loss of power, and then they will fight to retain it. And then we're stuck where we are. And guess who loses in the end? Patients.
Patients. Absolutely. Absolutely. Wow. Well, on that point, I am going to just wrap up, and I want to say thank you so much again for taking time to speak with me on this podcast. And I may tap you again in the future because there's so much. I had so many other questions that I wanted to get to. So there may be a part 2, and I'll be giving you a call.
Let's go. Congratulations, Lillian. I know you have a lot going on. This is what I love about nurse leaders, to create space to have these conversations. I would not underestimate the impact of it. So thank you for all you do.
Absolutely. Thank you so much. And thank you all listeners. Be sure to tune in to wherever you listen to your podcast. And we are finishing up this episode with Dr. Zayna Khayat and futuristic. Now we can't even say it's healthcare now, in the here and now.
The future is here
Thank you.
today.
Absolutely. Thank you so much.
Nephrology Nursing Perspectives is owned and produced by the American Nephrology Nurses Association, all rights reserved. No portion of this podcast may be used without written permission. Dr. Zayna Khayat is the In-House Health Futurist with Deloitte Canada's Healthcare and Life Sciences practice. She is an adjunct faculty in the Health Sector Strategy stream at the University of Toronto's Rotman School of Management instructing courses in healthcare innovation and partnerships for the Health MBA program. Dr. Khayat also serves as a growth advisor at Teladoc Health in Canada and advises several emerging health startups. Previously, Dr. Khayat led the Futures team at SE Health, a national home healthcare and aging social enterprise, where she served as their Future Strategist. She also held the position of lead for health system innovation at Mars Discovery District, a health innovation hub in Toronto, Canada. In 2017, she was seconded to the REshape Innovation Centre at Radboud University Medical Centre in the Netherlands. Dr. Lillian Pryor is Dialysis Program Manager at In-House Health Rehabilitation Hospital of Henry. A member of the American Nephrology Nurses Association since 1990, Dr. Pryor has served in roles that include President-elect, ANNA Director, ANNA Awards and Scholarships Committee Chairperson, ANNA Representative to the Kidney Health Initiative Patient Preference Task Force, and an author and peer reviewer for the Nephrology Nursing Journal. Dr. Pryor served as the 2020-2021 president of the American Nephrology Nurses Association. In addition, she is an active member of ANNA's Dogwood chapter in Georgia and has served the chapter as both its president and health policy representative. For archived episodes of this and all ANNA podcasts, and to learn more about the American Nephrology Nurses Association, visit annanurse.org. You can subscribe to Nephrology Nursing Perspectives everywhere podcasts are found.